Okay, so this morning we are talking about a number of things, actually. It's quite a big section. We're talking about movement disorders, tremors, and ataxia, paresis, paralysis. And essentially, the section of Edinger that we're going through at the moment is clinical presentations. So all of these clinical presentations might have a number of differentials. And we're trying not to get too deep in the kind of pathophysiology of each differential, but just like working out a bit of an approach to different presentations and learning how to recognize and define different presentations. So the nice part about this section of Edinger is there's a fair bit of pattern recognition in it. And I feel a little bit like, when the teacher comes to school hungover or something and they just put on a video for the students. I was preparing for today and just going, oh, we'll show a video of this. Oh, we'll show a video of this. We'll show a video of this. So it's actually very planned and I'm not hungover at all. So don't be judgy, but we're going to probably go through a fair few videos today. So just going in order of Edinger, the movement disorder chapter was first, but I feel like clinically that's probably the least important of the chapters that we're covering today. So I don't want to spend too much time on it. Does anyone know what a movement disorder is?
It's a term that classifies different neurologic presentations.
Pretty much. Yeah.
Yeah, and they were talking about like paroxysmal dyskinesia, fainting syndrome in cocker spaniels, epileptic or seizures, and they were kind of like telling us the differences. And yeah.
So essentially a movement disorder is any abnormality of movement, and it can be kind of divided out into hyperkinetic, so increased movement, hypokinetic, decreased movement, bradykinesia, slow movement, or akinesia, or lack of movement. And essentially dyskinesia is abnormal movement. So what we're talking about are dyskinesias essentially today. They then kind of divide. Can anyone sort of think of any common abnormalities of movement that we see?
Are we talking about like clinical signs like ataxia or gait abnormalities like dysmetria, hypermetria?
Yep. So the way that they kind of break it, you're exactly right. So the other chapters that we're talking about, and this is why movement disorders is first, tremors, ataxia, paresis, paralysis, and myoclonus are all forms of movement disorder, but they're not they've got their own kind of categories and differentials, and it's kind of a different presentation when you can recognize and classify your movement disorder into one of those kind of subcategories. Does that make sense? So it's important to sort of be able to say movement disorder is a huge umbrella term that covers any disorder of movement or any abnormality of movement. And there are a whole heap of kind of individual little genetic disorders that are specific to breeds mentioned in this chapter, but the vast majority of movement disorders are going to fall under ataxia, tremor, paresis, paralysis categories.
Yeah.
So probably the big one that we're not going to talk about in the other chapters is myoclonus. Can anyone tell me what that is?
Because I guess the way I thought about it was myo comes from muscle and clonus would be like a repetitive movement. So it would be something related to the muscle and abnormal movement.
Yeah, exactly. So essentially abnormal muscle contraction or irregular, consistent muscle contraction. What would be, if it's not a movement disorder causing that, what would be a differential for that?
I guess toxicity.
Good. Yeah.
Yeah. Oh, yes, like when dogs get tremors, like idiopathic tremors, so due to the mushroom.
Yeah. So tremors can be localized or generalized. And a localized tremor would look a lot like myoclonus. But myoclonus typically describes that muscle fasciculation or muscle contraction, relaxation in one area.
Right.
Distemper dogs will have it. But distemper dogs do not.
Yes, exactly. And I think you're touching on kind of what I'm getting at. It can be kind of peripheral or it can be central. So what would, if you had a dog that presented to you with a back leg that would just spasm every now and again, and then they would be back to normal, what would be on your differential list just with that history alone?
Paroxysmal dyskinesia is most likely, if otherwise clinically normal all other times.
Is there any other centrally mediated disorder that might cause focal muscle contraction, relaxation?
Like a focal seizure?
Yeah, exactly right. Yeah. So the biggest sort of rule out in these disorders are focal seizures. So if we sort of think about what causes muscle contraction, muscle relaxation, what is it kind of from an action potential perspective? What changes in the cell to cause contraction of the muscle?
Potassium, potassium will have something to do with muscle.
Good. Let's talk about more generally rather than specific electrolytes. What happens to the electrical charge inside the cell when an action potential is generated?
Yeah, the resting membrane potential changes and becomes positive inside.
Excellent. Yes, good. Exactly. So can you remember? Oh my goodness, I'm going to challenge myself and try and draw this.
Ages ago, like first year of university, pretty much.
Yeah, it's so oh gosh, I don't know how to so can you see my whiteboard?
Mhm.
Amazing. Okay, I'm going to try and draw you a picture. We probably don't need to go through new tools right now. Thank you so much. So we've got negative down here, positive down here, and we're talking about inside the cell. So what's going on inside the cell? So normally your cell sits down here where the majority of ions inside the cell are negative. So you're sitting at a negative charge. When the nerve triggers an action potential, it triggers opening of the sodium channels and sodium rushes in and you get to the, not the resting potential, but the
Despolarization, is it?
depolarization. Yes, exactly. So you get to the threshold potential where depolarization is triggered. So some sodium ions trickle in and you get up to this threshold potential. And then that increased positivity causes a whole heap more sodium channels to open up and you get this huge rush of sodium into the cell. And then you get changes in calcium and stuff like that. And I don't want to go into too much detail because it's different in different muscles, like the heart versus skeletal muscle versus smooth muscle. But the calcium results in sustained contraction. And then we get return to negative, don't we? So what ions flow to result in that return to negative? What is the main cell pump or ion pump on the cell membrane?
The sodium potassium ATPase.
Great, excellent. And what is another negative ion that's going to have the most impact on negativity shift? A very common ion.
Chloride.
Excellent, good. So often in these myoclonic disorders, there's an abnormality of either generation of an action potential or resting cell membrane potentials. And often they're related to chloride ions. So if you think about a cell that is twitchy and easy to fire off, it's probably going to be sitting at a higher action potential or be unable to return to a resting potential well. So that might be a problem in the cell itself, or it might be increased neurogenic stimulation of that cell. So you might just get a whole heap of stimulation of those ions opening inappropriately. So they're the kind of two mechanisms I want you to have in your mind as causes of abnormal muscle fasciculation. Is it a cell membrane destabilization problem, or is it an increased stimulation from a neurologic perspective? Does that make sense?
Yeah.
Sort of broad categories. And I think talking about the individual abnormalities and like the weird sort of single genes that have been identified is probably something that if you see a dog that you're suspicious of a movement disorder, Google their breed and movement disorder. But I don't think going through all of them individually is going to be very helpful for us. Does anybody specifically want to go through any one in particular? No?
I thought it was very interesting, the breed that can have this gluten sensitivity that can trigger paroxysmal dyskinesia. And they were talking about how to test for gluten sensitivity in dogs. And I wanted to ask you, because you are an internal medicine specialist, did you ever test it for that?
I'm not sure we've got that in Australia, in the genetic line in Australia. So the disorder that Natalia is referring to is the paroxysmal dyskinesia in border terriers, which is in response to exposure to gluten, and you put them on a gluten-free diet and it goes away. It's really interesting. And it's the only real, other than local gastrointestinal, it's the only real systemic gluten effect that has been identified in dogs. Otherwise, they tend to be very tolerant of gluten. Do we want to just watch a video of that, what that looks like, just for... Yeah, okay. I'll work out how to do that. There we go. I know. There we go. Can you see this?
Yeah.
Okay.
Wow.
So that's completely resolves with removing gluten from their diet. And it's specific to border terriers. Never seen it in Australia, or never heard of it reported in Australia. It might be, but maybe they go straight to the neurologist and bypass medicine. So if we're sort of talking about, while we're kind of a bit physiology, and we're talking about either having a neurologic stimulation for altered action potential triggering, or having a cell membrane destabilizing trigger. And our differentials are epilepsy, which is a centrally mediated neurologic increase. So you can see that there's a bit of an overlap in those conditions. And as such, some of these movement disorders will respond to anti-epilepsy medications, particularly the medications that will alter either the, what is the main inhibitory neurotransmitter centrally?
GABA.
Good, that was smooth. Drop the mic. What about excitatory? There's a few, there's not really a main one. But...
Glutamate.
I reckon that's the main one. And then there's noradrenergic transmitters as well. But going back to GABA, what anti-epilepsy medications can you think of that will be GABAergic, or sort of amplify the inhibitory effects of GABA?
Benzodiazepines.
Excellent. Yep. One more. I'm just let my dog in.
Mm.
The main epilepsy medication, long-term management of epilepsy.
Phenobarbital.
Yeah, excellent. Good. So if you've got a centrally mediated muscle disorder or salivary gland disorder, and you amplify the inhibitory effects of GABA by adding phenobarbital or benzodiazepine, you might get an effect. Doesn't mean it's epilepsy, but you're going to alter the resting membrane potential and make it harder to trigger an action potential, and therefore you're going to get a reduction in signs. Not all of them, but some of them, particularly the centrally mediated ones. What about medications? Can anyone think of any medications that alter the cell membrane, like resting potential? It's hard. Yeah, I'll tell you. Because gabapentin is nobody really understands how it works. So it's one that will alter calcium and stabilizes the postsynaptic cell membrane. And the other one's an anti-epilepsy medication that we can't access. It's in Australia, it's got to be specially prescribed by neurologists for humans, called topiramate, I think. Well, the last time I tried to source it, we couldn't really access it. Maybe it's more available now. But it stabilizes the cell membrane as well. So it just increases the negativity inside the cell and makes an action potential harder to trigger.
What drug was that, Anna?
Topiramate. There's one of the mate classes that I've used in a refractory epileptic once that was like the thing that fixed the dog. And now I'm really fond of those drugs, but they're really hard to get. It's not based on any evidence or consensus statements on what you should use in epilepsy, so don't listen to me. One case, come on. So I guess it's important if you're sort of thinking, is this epilepsy or a movement disorder? It's just important to have those mechanisms in your head, and you might go, okay, let's do a medication trial, and you're not necessarily ruling one or the other out. But if our goal is to relieve clinical signs and improve quality of life, then it might be worth a go, even if they can't do further diagnostics.
Right.
So if we now move on to talking about tremors, what is a tremor? What triggers a tremor? Sorry, my dogs are patting in the background. One dog's got their mouth and the other dog's mouth.
It's like a rhythmic movement.
Right. So the big difference between a movement disorder or a dyskinesia or one of the kind of the subcategories of dyskinesia where like the individual like cramping ones, it's Scotty cramp and the border terriers and stuff, is that it's not rhythmic. Tremor is always rhythmic. And there's such a variety of tremors. We've all seen like different, like really coarse, fine, generalized tremors, and then like, you know, the Cushing dog that's weak in the back legs having a little tremor in the back legs. Like there's lots of different types, but the main thing is that it's rhythmic. Does anybody know mechanism-wise why a tremor is rhythmic? Nope. So if you're in a standing position, your brain and muscles are constantly feeding back extensor, flexor, tone with your vestibular system. So to maintain a standing position, you're constantly balancing excitation and inhibition of flexors and extensors to maintain that still position. So essentially, if you get that loop slightly out of whack, you'll start getting extensor flexor, a loss of synchronicity of the tone in them. So you'll get a little bit of overextension, a little bit of overflexion in response, a little bit of overextension, a little bit of overflexion. So a tremor is just that anywhere in that sensory, central, vestibular, motor pathway, any loss of synchronicity and coordination in that. So knowing that anywhere along that pathway might trigger a tremor, what different types of tremors do we see commonly?
Intention tremor.
Good. Yeah.
But that would involve the cerebellum, wouldn't it? Because one of the classic signs for cerebellar disease.
Did you say it doesn't involve the cerebrum?
It will, like it is one of the classic signs of cerebellar disease.
Yes, yeah, exactly. So what's the cerebellum's job?
It's like a modulator. It doesn't really do like it just modulates
Of what?
movement and
Movement.
balance.
Exactly. Good.
I mean, not so much balance, but I think little bit balance too. That's why with vestibular you do get that affected.
Absolutely, yeah. And vestibular system's intimately associated with movement, isn't it? Because it's what? So if we think about, so if I tip to the left, my vestibular system tells me that I'm tipping to the left, goes to my brain stem, which says extensor tone quick, and then I do extensor tone, but without cerebellum smoothing that movement, I'd actually tip the other way. So the cerebellum coordinates, smooths, tones down, like dampens down that immediate vestibular brainstem response. So if you lose cerebellar control, I'm going to go like this, aren't I?
Yeah.
Yeah. But that's only when I'm trying to initiate movement. So that tremor is a kinetic tremor. So it's a tremor that's associated with initiation of movement. When I'm sleeping, will I be tremoring? Good. Excellent. So that's one of the big differentiators. If you've got a dog that's tremoring, categorizing it into a kinetic versus a consistent tremor can help you localize it, because it's not going to be cerebellum associated. If they are at rest, they're not tremoring.
Right. Oh, so that's the difference between intention and at rest tremor. I was always imagining it was the animal wanted to do something and they intended to move.
I couldn't.
Right. Okay. Okay.
There's more than one type of kinetic tremor, and intention is one of the forms of kinetic tremors.
Right.
So when we see kind of magnification of that cerebellar one is when they're trying to do a fine task that they're concentrating on a lot, because that requires a lot of fine control. So I think the classic is trying to eat, trying to coordinate oral, like visual, oral, tongue. Like there's a lot of little muscles involved in eating, and that's when it gets really kind of clunky, is when the cerebellum should be working really hard and it's just not doing its job. But then there's other types of tremors that will occur with movement as well, that aren't necessarily cerebellar in origin. So has anybody ever done a workout and you've been holding a plank for a really long time? What do your muscles do?
Yeah, they start to.
Yeah.
Tremor. Yeah.
Yeah, exactly. So you can have a kinetic tremor associated with fatigue. So that there's like physiologic causes of tremor, which would be appropriate. Like what's another situation where you might shake and it's really appropriate?
Shiver.
Like when you have fever or hypothermia.
Yes, exactly. So thermoregulatory reasons. What else have I got? What sort of electrolyte disorders might result in a tremor as well? Just altered action potential.
Calcium.
Good. Yeah. Calcium, potassium. One more.
Would chloride be one then?
Potentially, yeah. Sodium's probably more common. I think because we don't really see disorders of chloride unless it's disorders of sodium as well. But like platotoxicity, they definitely get altered membrane resting potential and tremors associated with that. Also other signs, but and then a tremor that's happening at rest could easily be one of those physiologic ones, couldn't it? Could be a mycotoxin. Anything else?
I mean, with the corticosteroid responsive tremor syndrome, they do like sometimes they tremor even at rest. So where would you put that one in then? Because that's cerebellar disease.
Is it localized cerebellar disease always?
I thought yes, because like you have to have the cerebellum involved. So
Yeah, definitely the cerebellum's involved, but sometimes it's actually a mixed tremor. So sometimes you can get vestibular brainstem involvement as well. And yeah, I'm not sure what.
Because isn't the other name for it, like earlier it used to be called cereballitis at some point? Like it's all the same thing, or is it not?
Yeah, well, that's why they changed it, because it's not actually localized to the cerebellum. So
Okay.
there's cerebellum involved, but most of those dogs will stop tremoring at rest. So often they're acute presentation, and one of the kind of differentials which helps you say, okay, I think we can probably manage this conservatively or as a toxicity versus as a potentially progressive inflammatory disease is stopping tremoring at rest. You're right, they don't all stop. They slow down.
Yeah, that's wrong.
Yeah, but it's not that condition's not discrete to the cerebellum. There are other areas of the brain affected, and sometimes they'll have just a mild, like what's it called when the CSF has white cells in it?
Pleocytosis.
That's one. Thank you. There's a bit more systemic inflammation and meningeal inflammation involvement and stuff there. A little bit. Has anybody seen any genetic causes of tremor?
I don't think so. Me.
There's one that we see locally in Sydney with Kelpie, in the Kelpie bloodlines, which is a cerebellar. It's a degenerative cerebellar disease. So they're born pretty normal and they're pretty normal early in life, but by about 1, they start doing this. You know, when you like, I just really like dogs, and I go to the dog park with my own dogs and I walk around and stuff like that. And you'd see it. I saw a Kelpie just locally going like this, like a young Kelpie, and I was like, oh no, do I say, what do I do? It's like my life and my job are like intersecting here. I'm not sure I need to it's my role to tell them about this, but you should go to the vet. You should go to this vet that I know knows about this. What about, so there's actually a lot of degenerative cerebellar diseases, but again, if you see a young dog come in with a intention tremor that's gradually progressive, Google their breed and just see if there's anything genetically that's been reported. So we talked a little bit about the idiopathic cereballitis, idiopathic white shaker dog syndrome, idiopathic corticosteroid responsive tremor syndrome, idiopathic generalized tremor syndrome, which is the new name. If you have a young, like, let's say we have a 3-year-old Maltese who comes in with an acute onset generalized tremor and no reported access to toxins and normal bloods, what are your other differentials?
Hypocalcemia.
Normal bloods.
Oh yeah, normal bloods.
So ruled out.
I guess. Google it. Google the breed.
Definitely Google it for sure. But there should be, in particularly with that sort of signalment, it might be kind of idiopathic generalized tremor syndrome, which is fairly kind of responsive to medication and good prognosis, I'd say. What's another differential that you should be on the radar? Another inflammatory disease.
Oh, meningitis.
Good.
Encephalitis.
Yeah. So I think the big, it's almost impossible to differentiate. They call it meningoencephalitis of unknown etiology often because we don't get the histo to be able to say it is GME or it is necrotizing meningoencephalitis. So yeah, meningitis of unknown etiology is a differential that requires a lot more intensive management and has a much poorer prognosis and does like to get into the cerebellum, so can present almost exactly the same as a shaker. How would you differentiate that?
CSF?
CSF, yep, exactly. What would you expect to see in both diseases?
Pleocytosis.
Yeah. And would one, like, sort of range of pleocytosis, would they differ?
I guess the meningoencephalitis would be worse, more severe inflammation.
Sometimes, disappointingly not.
I
always.
don't think so, yeah.
The GME or the MUO, let's call it MUO. I get confused because they say MUE, but our etiology starts with an A.
Yeah.
So meningitis of unknown origin, meningoencephalitis of unknown origin. So if the lesions are up against the meninges or up against the surface of the neurological system, you will get inflammation in the CSF. But if they're in the actual brain tissue itself, it doesn't exfoliate inflammatory cells. It doesn't cause a meningitis. So sometimes you can have completely normal CSF. So what I'm getting at is there's actually no way of really definitively saying this is got a terrible prognosis and is going to need like probably long-term high doses of pred and maybe some chemo, or your dog's got a completely like normal life expectancy if we can get through the next kind of 3 relapses over 12 months.
Would you ever see with MU, would you ever just see tremoring? Like, would you not have something else, some cranial nerve deficit somewhere?
It can be so, the presentations of MU are so variable.
Yeah.
Yeah. I mean, I had a French bulldog that came in with, I thought it was a like a narcolepsy thing. Which is being reported more and more in brachycephalic dogs because they get such bad sleep apnea that they're so tired they fall asleep standing up. And we MRI'd this dog and they did the brain and they were like, oh my gosh. And then they caught the proximal brainstem and they said, oh my gosh. And then they did the rest of the spine and they were like, oh my gosh. And this dog there was more tumor in this dog, more granuloma in this dog than neurologic tissue. And it was the only sign was like falling asleep standing up. Basically, it was moving normally. It didn't have proprioceptive deficits or anything. And we didn't CSF that dog because it was a French bulldog and they're so crowded and I worry about herniating them when they've got intracranial lesions. But then we see other dogs that we MRI that are so severely affected and really neurologically abnormal, seizuring and things like that. And their CSF is got mild pleocytosis and the high albumin. We sometimes see high protein in the CSF, and that's one of the markers that there's inflammation inside that's not exfoliating. We see and then the MRI will be completely normal and they're really severely affected. So GME is just, we don't understand it very well. They think there's infectious links in some dogs, but it can manifest very differently.
Has anybody looked at CRP in CRTS versus MU? Because MU are like you can have CRP normal.
That's a really good question. I know they've looked at it with SRMA, but that's a more systemic inflammatory disease.
And usually with SRMA, it's much, much higher. So you can actually just diagnose it based on just CRP.
The mechanism of SRMA is a systemic vasculitis. So you'd obviously you're going to have more systemic inflammation, whereas a disease that's confined to the central nervous system, and if it's not even exfoliating into the CSF, I don't know how it would cause systemic inflammation. I'd be really interested. If you can find a reference, that would be amazing. Where's Josh with him? He'd know. So let's watch a video of the dog that I just described. Basically, it's going to tell you what is wrong with the dog, so it's not going to be like a mystery. But everybody, close your eyes. Did everybody appreciate that? Huh?
I always think that MUO dogs will look sad, but this dog doesn't look sad.
No. If they've got cerebral involvement or brainstem involvement, they often look sad, but it's so variable. And it can be like focal in the eyeball.
Hmm.
Does whatever it wants. You can definitely see that like balance between extensors and flexors, like if you're kind of thinking of it. Mhm. Yes. It's subtle, hey?
He's got an intention tremor. He's sitting and like doing this.
Yeah.
Standing, not sitting.
Yeah.
The vet's got nice boots on.
Oh, don't they? Sort of vet works in those shoes. That's got to be an owner for sure.
Surely that's the
white
owner.
pants.
Surely.
White pants, nice boots. She's not a vet. Sorry. Excellent. There's one more tremor disorder that I do want to talk about because it's one that we see. In fact, there's two more tremors. Sorry, one that we see quite commonly in French bulldogs and English bulldogs, and now that they're a little bit more common, it's good to have on our radar. I'll show you a video of what it is. Right. So, idiopathic head tremor. Has anyone seen it?
Yep.
Yeah.
They're benign. You don't do anything.
Yeah. Yeah, exactly. And sometimes it's months between episodes. Some dogs do it every day. Some dogs are bothered by it. Some dogs aren't. Sometimes it's a yes, yes, yes.
I saw it in a staffy.
Did you?
Yes. It was a
Interesting.
staffy.
Not progressive.
No.
Just stable.
No.
Oh, that is interesting. So sometimes it's a yes nod. Sometimes it's a no nod. No shake. But can be quite intermittent. And I'm sure there was something significant I wanted to tell you about that particular thing. But yeah, completely benign, non-progressive. Obviously, you need to rule out focal seizures. And if there's any accompanying alteration in mentation or postictal phase, or if they can't be if you can't get their attention when they do it, some dogs you can kind of snap them out of it. Then more likely to be seizure disorder. And in that case, I'd probably try on anti-epilepsy medication. Oh, where did I put it? Yeah, so the breed is reported in English and French bulldogs, Dobermans, boxers, staffies, and labs.
Ooh.
But it can occur in many purebred and mixed breed dogs. Most don't respond to anti-epilepsy medications, though some will actually respond spontaneously, will actually get better resolve spontaneously as they get older. So that's something nice that you can just tell the owners. It might go away. Don't worry about it. And then the other tremor that I think is worth kind of having on our radar is an orthostatic tremor, which can be primary or secondary. Does anyone know what an orthostatic tremor is?
Sounds like it's a tremor while you're standing still.
Yeah, exactly. I love the term anti-gravity because it makes me think of dogs in space. But when you're using your anti-gravity muscles, like extensors and particularly the cervical neck muscles to hold the head up against gravity, it's a tremor when you're in the anti-gravity position.
Wow.
He looks uncomfortable, doesn't
Yeah.
he? Mm. So what we can't probably appreciate very well here, but in the text underneath the video, they've written there's gross tremors evident in the limb and trunk musculature. What he's doing, that shifting weight between the legs, that's not actually the tremor. That's because he's uncomfortable load bearing and he's trying to shift the weight around to get comfortable, essentially, which is something that's reported in humans with the primary orthostatic tremor. Let's just look at a more common one that we see. So this is associated with peripheral neuropathy. Who's seen this in an old golden?
Yeah. Okay.
Yeah. So often, I mean, I think a lot of large breed dogs, but Goldens in particular, get both hip and lumbosacral problems and entrapment of the sciatic nerve, damage to the sciatic nerve, which causes demyelination and altered, as we talked about, anything along that sensory, central or motor pathway. Demyelination of those lower motor neurons is going to alter the speed of transmission, which is going to alter your extensor versus flexor tone. So you're going to get that oscillation between extensor and flexor, which is going to cause the tremor.
Is that thinking in a polyneuropathy that could occur?
Polyneuropathy is a little bit different because it's often multiple nerves. So you end up with weakness. So you end up with a generalized decreased extensor tone. Whereas when it's just one nerve affected, and it might be a sensory and motor nerve, or just a sensory nerve, or just a motor nerve, you just lose the synchronicity between extensor and motor control. Right. So that flexor extensor balance means one's firing out of sync with the other one. So you get this kind of reactive sort of wiggle.
Yeah.
Don't all greyhounds have orthostatic tremor? They just stand in tremor, just generally.
I think that's just in the vet clinic. Oh. I don't know actually. Are they actually reported to have orthostatic?
No, I'm just fooling around.
Yes, you're actually It's just them.
Like I'm like, what is that classification? There should be something.
There should be, yeah. All right. So last topic I want to cover. Oh, any questions about tremors?
How do you differentiate? Because I find this sometimes challenging. I mean, obviously history does help, but you can't always rely on the history of the owner. Like differentiating between toxicity and corticosteroid responsive tremor syndrome, like it's sometimes a bit challenging. And to give and like to decontaminate an animal, I find I sometimes find that a bit challenging. Do you have any sort of tips and tricks? I mean, like I said, history will help, but apart from that, it's not always do they at rest. They don't always settle down. Like if they did, then yes, then it's easier, but doesn't always happen.
No, I don't think there's a really good way of differentiating. I think the dogs with like most of the neurotoxins that cause tremors will also cause hepatotoxicity, even at a low level. So often the ALT is elevated. And for me, I'm like, oh no, they had a multi-sandwich for sure. So yeah, I think there's a couple of like things that would make me hint in one direction, but there's no way I'd say to an owner, oh, I'm sure this is what it is. I'm just going to hedge my bets. Mostly I'm decontaminating and giving pred.
Okay.
Yeah. Or I think the big thing is like, do you do a CSF in these dogs? And if they stop at rest, then for sure I will. But if they're still going at rest, I'm like, oh, it's probably a tremor. I might just try both treatments and see whether it resolves in 2 days or 2 weeks. The worst case I've ever had, the idiopathic tremor syndrome, was a Dachshund. I just wouldn't get better. I needed so many drugs. It's terrible. Okay, last chapter is ataxia, paresis, paralysis. What is paresis?
It's weakness, pretty much.
As opposed to paralysis?
Paralysis is loss of motor function.
Right. Excellent. Yeah. So there's sort of a bit of a spectrum, but as soon as you lose voluntary movement, that's where it's called paralysis. And there's many causes of paresis, but paralysis is complete loss of motor function, usually spinal. Okay, now let's go back to ataxia, because paresis will cause, many of the causes of paresis will also cause ataxia, but there are causes of ataxia which aren't associated with paresis, so let's kind of consider this as its own category. What types of ataxia are there?
Proprioceptive.
Cerebellar and vestibular.
Okay, vestibular, cerebellar, and somebody said proprioceptive.
Mhm.
Yep, good. Exactly. So 3 different categories of ataxia. How easy is it clinically to differentiate them?
Cerebellar is easy because you often also will have other signs like either an intentional tremor or a truncal sway. So
Mhm.
cerebellar I think is definitely easier. Vestibular, like the way in my head, vestibular typically you'll have them stumbling, but
Mhm.
sometimes it can be a bit tricky with proprioceptive and vestibular.
Yeah. What other features of vestibular disease would help you localize it?
Nystagmus, head tilt. You don't always have to have nystagmus. By the time they come in, sometimes you can lose the nystagmus.
Yep.
Head tilt will give you a clue.
What about gait, other than the ataxia?
In vestibular,
Mm.
I think that it depends whether it's central or peripheral.
Good.
If it's central, they would have delay or absent conscious proprioception. I think, I'm not sure.
Did you say if it's vestibular, if it's central?
If central, they would have absent conscious proprioception or some reflexes.
Sometimes, yeah.
central always.
Sometimes. I find this really hard to differentiate. So what I was getting at with gait actually is more, are they circling?
Mm.
Because most of the time cerebellar causes of ataxia won't cause circling, and proprioceptive causes of ataxia won't cause circling, whereas vestibular will sometimes be lateralized. Head tilt, nystagmus, and I think let's talk about differentiating central versus peripheral, mostly when we cover vestibular system rather than get bogged down in there. But where I think vestibular and cerebellar are really hard to differentiate is that they're actually really close together. Vestibular nuclei sits right under the cerebellum. The cerebellum's job is to refine the signals coming from the vestibular nuclei and translate them into coordinated muscle contraction. So they've got kind of overlapping roles in the same department. And if you've got an inflammatory disease affecting the brainstem, it's probably putting pressure on the cerebellum. If you've got neoplasia, same thing, any space occupying lesion, you're probably going to get a combination of cerebellar versus vestibular. If it's big enough to cause cerebellar and vestibular, it's probably going to cause some proprioceptive deficits as well, because you're going to be disrupting some of those pathways through the brainstem. The only situation I think where we see really like quite symmetrical central vestibular ataxia is stroke, or ischemic stroke, I should say, rather than hemorrhagic stroke. But the one, like when you've got kind of a wobbly dog, or a dog that kind of, or a cat, actually cats quite commonly as well, that can't quite jump up on, they're kind of just off balance. They go like this when you've got symmetrical vestibular ataxia. So they get this kind of sway. I was studying this and showing Craig videos and explaining everything. Craig's not, my husband's not medical at all. When I was studying my fellowships, and he called it sad elephant when I was describing central vestibular disease. So if you just remember the sad elephant, probably symmetrical central vestibular disease, and often because of the way that the arteries supply blood to that area, often central vestibular disease will present like that. So let's have a look at some visuals of the different types of ataxia.
So will bilateral ear disease, won't it? Because bilateral peripheral will also, like, they do this.
True, so true. But usually they've got a history of one starting before the other. So they start with a head tilt and then it goes away.
Okay.
Or they start with nystagmus. And then the other thing with central vestibular, often they don't have a they don't have a spontaneous nystagmus when they're in their normal position. But when you flip them over and put their head in a weird position that they're not normally in, sometimes you can trigger it. And that's a really good test to do to differentiate vestibular versus cerebellar is flip them over. So vestibular ataxia. I wish I didn't have labels. I wish I could use this as a quiz, but whoa. Yeah, he's tending to walk towards the left.
Mm.
And he doesn't have a head tilt, but he seems to have a head turn, doesn't he? He's definitely got
Yeah, he seems to have a
corticollis and he's tending towards being a bit curled around on his left-hand side. Oh, there's a bit of a head tilt there.
I find head tilt and head turn, the differentiation, really hard. And it's so important because head turn neurolocalization is forebrain.
Mm. Oh, they can definitely thalamic. There's a really good paper on the different presentations of ischemic stroke.
Mhm.
And torticollis and head turn is really common, surprisingly, with thalamic stroke.
Thalamic lesions. Oh.
Yeah. Excellent. Let's compare that. Or let's talk quickly. What are the features of a cerebellar ataxia?
You have a like hypermetric.
Yeah.
Good. Excellent. And what about a proprioceptive ataxia? What would you expect the gait to look like?
Wide-based.
But with proprioceptive ataxia, they wouldn't have head involvement, right? You would only be like in the extremities.
Exactly. Yeah. So it might only be the hind limbs, might not be all four limbs if it's a lesion caudal to T2. If it's all four limbs, it might be obviously it might be a lesion in the cervical spine, and you'll still get all four limbs, which makes those ones are a bit harder. But interestingly, the pathways. I should read you this sentence because it blew my mind and made me laugh at the same time. The level of detail that the specialists who write these chapters think is reasonable knowledge. Are you ready?
Yes.
The dentate rubro-olivary tract linking the dentate nucleus of the cerebellum with the contralateral red nucleus and the inferior olive nucleus is of pivotal importance. Did you know about that?
I have to read that at least 3 times.
I'm going to remember that in my lifetime. So what that's saying is the link between the vestibular system, the brainstem, and so the peripheral vestibular, central vestibular, and the cerebellum, very important, pivotal.
Probably so paradoxical vestibular would probably then involve cerebellum. Like that's why it's paradoxical.
Yes, exactly right. So this is well outside the scope of what we should talk about today.
Yes.
We'll talk about that with vestibular disease, but the cerebellum's job, yes. Good point. So the main thing with a proprioceptive ataxia, where a cerebellar ataxia is increased, the phase of movement where they pick up their feet is exaggerated, but also when they put down their feet. So they kind of go really hypermetric, so every movement is exaggerated, as opposed to a proprioceptive ataxia where their gait floats a little bit, and we'll watch a video. I think there's a video here. So they don't have exaggerated movements, and sometimes they're actually a little bit weak, but they often just pause before they put their foot down. Now you'll get gait abnormalities, you'll get that floating proprioceptive ataxia before you get proprioceptive deficits. And there's another sentence in here similar to that one about why. But it's just to do with that the pathway is not 100% squashed yet. But we're starting to get some sensory abnormalities. So let's watch cerebellar ataxia. Whoa. We talked a lot about dogs with cerebellar disease. We didn't talk about cats. What's the most common cause of cerebellar disease in cats?
The hypoplasia, panleukopenia, secondary
Panleukopenia. Good.
virus. Yeah.
Yeah.
Mm.
This cat has all 3 hallmarks of cerebral disease. It's good.
Yeah, it's good.
Good cat.
The hypermetric in the hind limbs in particular. Whoa. Where are they? I don't know. Okay, and then the last one. So this is a proprioceptive ataxia, but it's obviously the underlying cause is a wobbler, so it's cervical. So we're going to have all 4 limbs. It's a wide base, like Ron said.
But the thoracic limbs have short, choppy.
They are a bit choppy, aren't they? Can you see the pause before he puts his foot down, though? He just hesitates a tiny bit.
Hmm.
Mm.
I reckon proprioceptive is the hardest for me. Like I sort of, because dogs walk weird when they're on the lead, don't they? They're pulling and doing strange stuff.
This looks like a C62 to me. Like,
But
if I had to look at this and localize.
Yeah. What did it say? Did it say where it was localized to in the beginning?
I don't think it says anything. What
No.
does it? No.
No. It says cervical. I mean, it could be caudal cervical for sure. All right. We'll probably have to wrap up there. Any questions about ataxia?
No, that was interesting though.
You guys are good in this part. So next fortnight we're covering seizures, which is quite a big topic, and I do want to go into neurophysiology, a little bit of seizure generation, and mentation changes, stupor and coma. So we will cover that in a fortnight. In the interim, happy Easter.
Oh yeah.
Yeah.
Thank you.
Guys, see you later.
See you guys.
Bye.
Yeah, guys. Thanks, Anna. Bye.